correlation between some substance, some mysterious substance, and oral tissue that would indicate that it possibly could be useful to treat disease. Okay, so for dental products, let's say a mouthwash that kills bacteria, maybe helps with the early stages of periodontal disease, we can kind of simplify the evidence pyramid to sort of a step, kind of like an Aztec pyramid here. Okay, but really the basis for proceeding with people on a large scale is how randomized controlled trial results work. Okay, so basically, though, the pyramid has to be anchored on a firm foundation. And I think that in vitro laboratory studies, maybe animal studies, if appropriate, are really a very good foundation for the evidence pyramid. And without a good foundation, we risk, rather than having an evidence pyramid, we risk creating a leaning tower of evidence where essentially we have this, but it's not really based on a firm foundation. Okay, so there's a risk that the whole thing will topple over. So who are technology stakeholders? You know, who's involved? Really, what we're talking about here is the ability for the dental profession, just like the medical profession, just like any other profession, to innovate, to essentially expand, to move forward. Okay, so our consumer is an evaluator. They have to be safe. They have to be able to perceive efficacy. We have various types of testing, and the early stages, however, will be done by, you know, the inventor or people that the inventor work with, who will evaluate technology at a very early stage. Okay, first let's talk about antimicrobials. I know much of this course is devoted to microorganisms, bacteria. You know, when I go to dental meetings, etc., there are always ideas for a new mouthwash, etc. And very often some of the evidence to support a new mouthwash will be you take bacteria that are growing in a liquid media, what we call planktonic bacteria. Okay, so bacteria that are essentially free floating in their media, you put a small amount of an agent in, and you determine what percentage of the microorganisms get wiped out. So people will say, and I have heard this, that, oh, we put such and such an agent in a mouthwash, and in a test like this, it kills, you know, 999, etc., out of 1,000 bacteria. So you know, what would this be? This would be a 3-log unit kill. Okay, something like that. Okay, massive kill. Yes, but is this really a good test of what goes on in the mouth? In other words, how microorganisms live in the mouth. Okay, so, and the answer is it isn't, because as I'm sure you've heard in some of these presentations, really the important media for bacteria on teeth, in the gingiva, etc., is a biofilm, where teeth live in a mass protected by an extracellular matrix where there's often multiple species of bacteria. So really free floating in a media is maybe an initial, but not really a very good test to determine whether an antimicrobial agent would be useful clinically. Okay, some of the other ways that antimicrobial agents and antibiotic drugs are tested is the dilution method, where we have bacteria growing in a liquid medium once again, and where the bacteria are present, that liquid media turns cloudy, you know, like soup or whatever that's gone bad, it gets cloudy. Where it's clear, that means the bacteria have been killed. Okay, so we can test different dilutions of a drug. Let's see, so 1 to 2, 1 to 4, all the ways up. In this case, let's see, what does that say? 1 to 512. And we can determine essentially what concentration of the drug is necessary for killing a particular type of bacteria. So in this case, we tested a antibiotic, I'm not even sure what it is, against E. coli and Staph aureus. And actually, even very low concentrations were capable of killing Staph aureus, but E. coli, it didn't get killed unless relatively high concentrations were used. So this can tell us the inhibitory concentration for an antibiotic. Another popular test of antibiotics is to essentially grow bacteria uniformly on the surface of a petri dish. So here we see petri dish, and notice that the surface in most areas looks hazy, fuzzy, but we can see little streaks here. So this is where bacteria was introduced onto a petri dish so that it formed what is called a lawn. It's like a uniform growth of that bacteria. And then onto this lawn, there were different discs containing different antimicrobial or antibiotics. Okay, so the area where the antibiotic kills the largest radius around itself, that indicates the greatest kill for that particular antibiotic. So for instance, whatever antibiotic was in this disc is more effective against these organisms in this test. Okay, we got to qualify it, than this antibiotic, which gave us a very small zone of inhibition. Now, both of these tests ignore a lot of things. You're not really dealing with biofilms here. And they also ignore really the world of our body. Okay. In other words, how our body absorbs, metabolizes, breaks down, et cetera, where drugs go in our body. So it ignores what's called human pharmacokinetics. But this is a screening tool in the laboratory. Now, a lot of times people will see that a antimicrobial or a new substance will exert a lot of antimicrobial effects in simple tests like this. So they go, oh, this is like how penicillin was invented, and this is going to be great. Well, actually, it is how penicillin was invented or discovered, but it doesn't mean that every drug that does that is actually going to be a clinically useful antibiotic, especially now that, we have choices, okay? Whereas in the early days when penicillin was discovered, we didn't really have choices. Now, there's the problem of resistance. It's a whole complicated story here, but still, this is only really the first step, okay? This is a slide from Dr. Kaplan, who's a member of our department, that biofilms, however, are extraordinarily important in human health and disease. So if you have a tube in your vein giving you fluids and whatever, if that tube stays in place for a long time, it'll start to accumulate a biofilm, and those bacteria in the biofilm can then cause serious, even life-threatening infections. So this is a major, major problem in people that are in the hospital for a long time. So Dr. Kaplan experimented with various methods to try to dissolve or break up biofilms. And one thing he found was actually an enzyme made by the AA bacteria that that Dr. Kachlani's talked about. That enzyme actually can unhook biofilms, so it can allow biofilms to be broken down on catheters and other medical devices. This is, I think, really classic work by Dr. Fine and Mr. Furgang, where they looked at how much antibiotics were needed to kill a particular type of bacteria, whether it was grown in a biofilm or, once again, growing planktonically, like just floating around a liquid media. Okay, so this was species or strains, rather, of the AA bacteria, either grown in a biofilm or grown planktonically. The strain would have those properties. And in all cases, it required more of the bacteria, a higher concentration of the bacteria, to kill the biofilm than to kill the planktonic organisms. And they actually did similar experiments using oral hygiene products like Listerine and chlorhexidine. And they found that, Listerine actually has the ability to cut through a biofilm a little bit. So that makes it very valuable as a clinically useful oral antimicrobial agent. Okay, taking this a step further, okay, so this is where I kind of come into the picture here, or actually, this was done before I joined, but I I think I perfected this anyways. What we want to do is grow biofilms, not only on teeth, okay, but on easily accessible and measurable surfaces. So we use little tiles here made out of hydroxyapatite. Hydroxyapatite is the very insoluble calcium phosphate salt, and it's the stuff that enamel is made out of. So it's basically, these surfaces represent artificial tooth surfaces, okay? We can tell ourselves that. It sounds good to us, that these are artificial tooth surfaces. So what I did was I took impressions of research volunteers, okay? Nobody was forced to do this, volunteers. And I made the little gadgets, and into each gadget, I would be able to insert 4 of these little hydroxyapatite squares embedded in wax. Okay, so the patient would wear this, the subject would wear this, and then at various intervals, I would take one out, put it into a test tube, and then our microbiologist, Mr. Furgang, would basically put this on an agar plate, put it in a appropriate environment, and see what bacteria grew. So in fact, anaerobes in the mouth are very difficult to culture because oxygen is actually toxic to them. So one of the things that we were able to do, or I would say the microbiologist was able to do, is essentially take a specimen and very quickly put it into a anaerobic environment. So this is a chamber where there is essentially no oxygen, and it's nitrogen gas. Any little bit of oxygen that actually got in here would basically be reacted with hydrogen. Isn't that amazing? It was almost like a catalytic converter to get rid of any traces of oxygen here. So this was a anaerobic environment, you know, with glove boxes, the whole bit. Okay, so this is actually some of the results we got. So this is just accumulation of microorganisms on these surfaces. So from a few minutes to about, 7 hours, we get a big increase in various types of microorganisms. 4 subjects that had AA, that we knew had AA on their buccal mucosa, they also developed some colonization of these surfaces with AA at some of these time points, which shows that AA can get in there and be sort of like part of the early plaque. Okay. Now, the usefulness, though, of this is that you can actually test antimicrobial compounds, maybe even antimicrobial compounds that aren't really approved for human use, using this system. So this is actually, I think this was a great test, but it didn't actually work for the product we were testing, where we tested a negative control, an active, versus a positive control. Now, the positive control here was Listerine. I can't tell you what the active was. That's a secret, okay? But anyways, the data clearly shows that there was no reduction with either, no reduction in microorganisms with either the negative control or the active that we were testing, showing that the active didn't work. That was the problem, okay? However, the positive control caused a nice reduction in bacteria. This was, you know, reproducible with whatever sample size this was. Doing this with a clinically used antimicrobial, I think this was zinc chloride in a toothpaste. There was also, you know, modest but reproducible reductions in the levels of plaque on these little squares. This kind of system could also be used to look at staining. Okay, so this is T stain on one of these squares, and we only really see the T stain on squares that were also exposed to saliva. So when our teeth get stained by things like T, it's probably we have the tooth, the saliva protein, and then the stain on top of that. That suggests that kind of view. Another problem that can be looked at in vitro in a system like this is denture candidiasis. Candida albicans is a common fungal organism in the mouth. And, you know, it's said that Candida is a sickness of the sick. So many people that get Candida infections have immunosuppression, severe diabetes, but healthy people can get candidiasis if you provide the Candida with an environment it loves a lot. It's very, very happy with. Okay, so as in other areas of oral health, the concept of population shifts, dysbiosis is very important on your teeth and also under the denture. So if you don't take your denture out, basically you're creating a fantastic environment for Candida albicans. So what's called denture stomatitis, redness with white areas, this is a result of poor denture hygiene and infection of the denture surface with Candida albicans. Okay, so we kind of looked at how can we make like a model of this. So what we did was Dr. Kablin and other people in the department here, we made little, not hydroxyapatite, these are denture acrylic squares. Okay, so now that the technology of making dentures has extended to digital and 3D printing and all that stuff, we're now actually looking at how those surfaces actually serve as a media for Candida albicans colonization. So here we see a surface stained for Candida albicans. I guess these areas here probably represent areas where it's growing in a yeast, okay, and they're also hyphae. And basically, Candida likes a little roughness of the surface. So the question is, how do we make the insides of dentures? Do we try to make them very smooth, or do we try to really reflect like the physiological appearance of areas like the palate? So the way we're taught to do it in dental school is basically when you take an impression of a person's palate, it should be almost like a fingerprint. It should have the real fine detail. The question is, do those little fine details provide nooks and crannies where Candida albicans will really love to proliferate? Do you really need them? Like we're kind of taught that you are, so those are all very interesting questions that we can basically address with these in vitro systems. A little more sophisticated. We also did studies of whether these can be used for anti-Candida compounds. So this was work with Dr. Gil Diamond, who's also a former member of our department. And basically, we actually were able to, or he was able to bake in anti-Candida compounds right into the denture acrylic. So we were able to document if these surfaces, in fact, inhibited colonization, adhesion of Candida albicans. Okay, moving on. So this is really going to be kind of like a potpourri of in vitro methods. I'm very interested in tooth sensitivity and really the physiological mechanism of tooth sensitivity. And, if you want to, you can get, actually it's available for free from the library, so we might as well get it. There's a Springer book on tooth sensitivity, and we just did a new edition of that, and I have 2 chapters, and I think it's a very good book. And, as Abby Hoffman said, steal this book. I mean, because the university pays for it. So we might as well just download it and, take it with us. Okay. So anyways, the mechanism of tooth sensitivity is the dentin has these little tubules, okay, that run the entire length of the dentin. And if dentin gets exposed, so let's say a person chips off this part of the tooth here and you blow air there, what'll happen is fluid shifts in these dentinal tubules tug on the cells and the nerves that are located at the border between the dentin and the inside of the tooth is the dental pulp. All right, so excuse me for not, maybe if you don't know really where you are here. The outside is enamel. The part that has the tubules is the dentin, and then the living tissue, what we all call the nerve, okay, is the inner part of the tooth. Okay, so if dentin is exposed, fluid shifts can induce sensitivity pain. So one way to treat that, and this really lends itself to in vitro studies, is essentially we take a piece of dentin, we put it in a chamber named after my good friend Dr. Pashley, and we can actually measure the ability to force fluid through the dentin. If dentin becomes clogged, essentially, that should correspond to the ability to reduce sensitivity, because the ability to, move fluid through the tubules, that's what actually makes the dentin sensitive. Okay, so we did a lot of experiments when I was in industry, and this was a very good method. And actually, one thing that really kind of predicted, well, it predicted clinical success. I don't think it predicted commercial success in this case, was that certain agents that can form mineral, like bioactive glass, okay, essentially over a period of time and with exposure to saliva, was able to really clog up those dentinal tubules and reduce the dentin permeability, measured, with a very simple apparatus like this. Okay, so this was one of the things I discussed with my person that was interested in testing this morning. And oh, by the way, we do have a really improved clinical research apparatus and organization within the school. So what I asked this person to do, and I think all our faculty should be doing this, is, write something up, put your ideas together, and I will submit it to Dr. Kotsakis's office, and we'll see what we can do, and frankly, we'll see what the costs are. Okay, that's a very important part of it also. Other things, silver diamine fluoride. This is a method to arrest and prevent caries. As you can see, though, there's a little problem here in that it tends to stain teeth very black. So this is generally not considered very nice looking, right? I think we can all agree on that. But this is believed to be an effective method of arresting and preventing caries. So with one of the pediatric dentistry residents, we came up with a very simple idea for a laboratory study. We didn't do very much of this. We never really got a good sample size here. It was a kind of labor-intensive thing, and it required actually collaboration with another party. So this didn't get very far, but I think the preliminary results were interesting. We took intact dentin or dentin that was soaked in acid, hence kind of simulating carious dentin. And first of all, you can see that the intact dentin doesn't really stain very much from the silver diamine fluoride, whereas the demineralized dentin did stain very intensely, indicating that, the demineralization kind of increases the uptake, okay? Under the microscope, we kind of counted the particles here, and I'll show you the particles in a second. Intact dentin, very low. Caries, simulated dentin, a lot higher, okay? And this is an electron micrograph. And what we see after we treat demineralized dentin with silver diamine fluoride. And so silver diamine fluoride, it is a basic solution of silver fluoride. Okay, it actually has a very high pH, so this could be irritating the tissue. The other bad thing about it here is that if you get it on anything, it'll stain it black. Okay, so if you get it on the furniture, if you get it on the patient's clothing, if you get it on the patient's clothing, you might as well just throw away the clothing, okay, because it's going to be permanently stained black. You get it on the floor, it's going to leave a black mark there. And I think our administration frowns on that, okay? So it's got its drawbacks because it's staining and it is kind of corrosive. Well, what we saw that after we treated surfaces with this kind of particulate material. So the question is, what the heck is that? Is that actually silver? So we took some specimens, and this is where we didn't really get that much work done because it was like an all-day thing to get a couple of these pictures. We took it to the biomaterials laboratory at New York University for very high resolution elemental analysis, which was really kind of neat. Okay, so what we did was there is essentially a target where you can aim an X-ray beam, very fine X-ray beam at a surface, and instantly get a elemental readout. Okay, so this is an area where we did not see the particles. Okay, we got phosphorus, calcium, In other words, what we would expect to be indenting. Okay. We then took the beam and we aimed it at one of these particles here. And well, okay, we also got phosphorus, we got calcium, but we got a big spike, bingo, of silver. Okay, it was like hitting the silver mine. So yeah, these particles, I don't think this is unexpected based on the chemistry, but essentially what happens with silver diamine fluoride is it leaves a precipitate of silver on the surface. It also leads to a lot of fluoride being exposed, the tooth structure being exposed to a lot of fluoride. So I think those things together. Silver has a lot of antimicrobial effects. People, I think, dose themselves on silver. You're probably too young to remember this, but in the news, there was the blue man. There was a man that drank so much colloidal silver, which is actually kind of similar to this, that he turned blue. Okay, so silver and other metals actually have a pretty significant antimicrobial effect. Forever, silver nitrate was used as a thing to dab it on wounds to arrest infection. And I think it's used on pupiks after birth to basically cause them to heal up, quickly and not get infected. I'm sorry, that means navels and not pupic. Okay, other things, we can test the effect of different agents on the adhesion of materials to dentin. All right, so all this could be used for dental material and tooth sensitivity screening. I'm going to skip that a little bit. We devised some methods of basically characterizing the surface if we treat it with a material, about how covered the surface is, because some of this is a little hard to tell from an electron microscope. It's often been said that electron microscopes allow you to lie with statistics because you can basically interpret them kind of however you want. But, we tried to develop more rigorous methods to interpret electron microscope pictures. Okay, I'm going to move them right along to other methods here and other ways of testing. I was involved, and this was work done with many of the residents in pediatric dentistry on assessing new technologies, devices to diagnose caries. Okay, now actually we are relatively unscientific about diagnosing certain types of caries. In other words, if we are looking at the biting surface of your tooth, when you go to the dentist, really the distinction is not, what's going on in a hidden level or below the surface, but essentially you need a filling if you have a hole in the tooth. Okay, for where the teeth touch together, that's where x-rays are in fact very useful if taken and interpreted properly, because in that location, you really cannot see the cavity. So you could actually get a fairly large and destructive cavity without seeing it. But for the biting surface of the tooth, if there is caries there, in other words, a hole, we don't fill it. And something, if we're not sure, what we do is cover it with a sealant. Pit and fissure sealants, there's some problem with insurance companies paying for this, but has been shown to actually be, what is the number? 89 point something% effective at preventing caries on the biting surface of the tooth. And there ain't nothing in medicine, dentistry, or in healthcare that's really more successful than that. So that's very important. So a lot of this has become a little bit of a moot point because we don't really need super duper accuracy. Basically, we're more following a clinical kind of guidelines. But there are a bunch of devices that came out, and they certainly were a lot of fun to kind of experiment on in the laboratory. So this is a laser device called the Diagnodent. And what the Diagnodent does, what the Diagnodent does is it causes the pigment in the tooth to fluoresce. So if there is caries-related pigmentation deep inside the tooth surface, you will get a high fluorescence number. Okay, so this device basically makes an annoying noise and it gives you a number readout. It does not, or the old version did not interface with the computer. So that was a problem. Somebody had to write down the numbers. Okay, when we talk about diagnostic tests, very, very quickly, how do we evaluate diagnostic tests? Well, the best thing is to compare our diagnosis to a gold standard. Okay, so cancer is actually a very good example. We can examine a person's oral mucosa, and we might have physical signs and symptoms, but essentially the gold standard is a biopsy to see if there is histologically the hallmarks of cancer in that tissue. Okay, so in other words, then, when we make a diagnostic decision, okay, there are 4 outcomes. We could say, yes, disease, and in fact, disease is present. We can say, oh no, that's healthy, and disease is present. Okay, now for cancer, that's bad news. Okay, so if we look at somebody and we say, no, you don't have cancer on your tongue, and they do have cancer on their tongue, that's very bad. Okay, if we then look and we say, oh, there is no cancer there, and that's correct. Okay, now what if we look and we say there's cancer there, and in fact the gold standard indicates that there isn't cancer there? Okay, it's a little wordy, but I think you get the idea. Is that really a problem? Okay, well, for cancer, we have decided that we would rather have what's called false positives. In other words, I'm not sure, let me take a biopsy. We would rather have that happen for cancer. And what we don't want for cancer is saying, no, you don't have cancer, and then finding out that the person, in fact, did have it. So we want to have, or we tolerate false positives. We do not want false negatives. So that's called sensitivity. So we want a high sensitivity for cancer diagnosis. I didn't realize this is the sliding part. Okay, now there are certain very specific signs of cancer. So this is a bad picture here, but a person that has really a big tumor in their tongue, in general, that usually indicates cancer. So there are very few false negatives using that as a diagnostic criteria. But many cancers will be a lot smaller and will be actually difficult for a patient to be aware of. So the sensitivity of that is unacceptable. So we have to balance sensitivity and specificity, and it's actually very different for different diseases. So actually what has been decided is that for caries, we want the specificity. In other words, we want to avoid the false positives. And we will actually tolerate false negatives. That might sound weird. Well, that means if I have a cavity and you don't drill and fill it, what's going to happen? Well, what should happen is that we will see it at a future visit. Maybe it'll get a little bit bigger, but not too much. Okay, so we'll be able to pick it up at a subsequent visit. So sensitivity and specificity. Now, how can we do this with one of these caries detection devices? Oh, I'm going too far back. The way we can do that simply, and this is not a perfect answer, is to do trials using extracted teeth. Okay, so one method we did, let me kind of skip to this, is using a device called the Spectra Caries Detector. And this actually does interface with a computer. You get a picture, and then you get essentially the device's caries designation as a color-coded map. And the manufacturer says, oh yeah, we call this laser Doppler picture, like a laser Doppler weather, laser Doppler picture of a tooth. That's sort of a good name. Unfortunately, it is neither laser nor Doppler, but other than that, it's a good name of the tooth surface. So it gives you this color coding where essentially, I think I'm going to skip this, where essentially, blue, it represents one type of caries, red indicates a different kind of caries. And I think that yellow indicates actually caries extending into the dentin or through the enamel. Okay, so very simply, what we can do here is we can do experiments where we do the diagnosis, we do other types of diagnosis, then we cut the tooth, and determine the gold standard. In other words, is there actually caries inside the tooth? So doing that, we can calculate the sensitivity and the specificity of this or other devices. So that's a logical question. You know, instead of telling me, oh, dentists love it, dentists hate it, what is the sensitivity and the specificity of the device? Some other things we've done is look at certain caries treatments to basically reverse the visual and the fluorescent changes of tooth surface. I'm not going to go into that too much here. Okay, so looking at essentially the sensitivity and the specificity, we did in fact determine that there was a certain value that would indicate dentin caries, but with minimum false positives. So using this, we can basically advise the manufacturer of what the ideal cutoff or threshold is. Okay. Now, once again, though, these devices should not be used, overused. They shouldn't be used to hunt for caries where they might actually be extremely minimum and not require a restorative treatment. That's the danger of these devices, that, they'll be misused. And in fact, the same danger exists with artificial intelligence. Everyone's talking about how fantastic artificial intelligence will be for evaluating caries on x-rays, but something, if it's too sensitive and it responds to things that in fact are not, I will say, not only not caries, but not very early lesions that do not require drilling and filling, then artificial intelligence can, in fact, harm people rather than help people. People think that, if I sit back and let the computer, do all my brain work for me, I'll just drill and fill more stuff and I'll make more money. But that's actually not consistent with what we're trying to accomplish in intervention for dental caries. Okay, we did also studies using, once again, extracted teeth. Do pit fissure sealants, essentially, do they eliminate the ability to detect caries or the advancement of caries on sealed surfaces? In fact, they don't if you use clear sealants, but we don't use clear sealants anymore, so that's a little bit of a problem. So in other words, all of these studies are done with extracted teeth. You could argue that if you work with an extracted tooth, you have the tooth in your laboratory, it doesn't really simulate what goes on in the mouth. And in fact, that is a valid criticism. And there have been studies done where they've tried to do these diagnostic determinations on wisdom teeth, okay, in the mouth. Okay, this is a very clever, very good experiment. Then extract the wisdom tooth and determine the gold standard. The problem with diagnosis in the mouth is you will verify the determination of caries being there, okay, but you won't verify the determination of a tooth being healthy because you're not cutting the tooth and seeing what's going on below the surface. So there's a little bit of bias doing this in the mouth, but I think doing it on teeth that either are extracted or destined to be extracted is a good alternative. Okay, last thing I want to talk about here is kits or technologies to determine caries risk. This is a very interesting system that we did some experiments. Dr. Duda, Dr. Strickland in diagnostic science, and pediatric dentists were also involved in this, where it is essentially a test, looks like a home pregnancy test or a COVID test. First time we did this, we didn't know whether we were going to get a cavity or have a baby, or actually it looks like a COVID test now, where we're able to detect Streptococcus mutans in high levels. So if Streptococcus mutans is present in over 100,000 colony-forming units per ml, we'll get a positive response here. Another test kit we evaluated was where you take some plaque, you put it in a solution that contains sugar and a pH indicator, and you try to measure how much acidification of that plaque occurs. Okay, so these were two kits. Both of them were made by GC. One of them was good. The other one was not so good. So let's see. So the strep mutans kit is a lateral flow sensor. And actually also, yeah, once again, very similar to a COVID test kit where we have our antigen. If it's present in a saliva sample, it'll complex antibodies, and the antibodies have a gold particle attached. So that is visualizable. Okay. Then as it flows, it hits the antibody again. So now you will have a antibody, antigen, antibody, gold particle complex, which you'll be able to see. Okay. If the either way, whether the antigen is present or not, the second strip has a second antibody. This needs two antibodies. The antibody to the antibody. Usually they're from separate species. I think one is like rabbit, the other is goat, anti-rabbit, something like that. So you'll have some of the antibody that's complex to the gold, and that will complex the antibody to the antibody. You'll get that also with the gold, so it'll allow visualization. So these kits always have a, where is that? Okay, it always has a control line, and it has a test line. The test line indicates the antigen. The control line simply indicates that the test kit is basically functioning. Okay, so this is control line, test line. Here we actually spiked it with a culture of 10 to the 7th strep mutans per ml, courtesy of Dr. Kabelin. This is a negative test. This is a positive test, not all that easy to see. And this represents a test where there is contamination of the mouth with food and stuff like that. So it shows that really, in order to test micro from a person's mouth, there can't be food, there can't be dental products, et cetera, et cetera. So actually, when used as directed, this test had a high sensitivity and specificity when we tested it on subjects that we predicted would be strep mutans negative, but not verified actually, and subjects that had early childhood caries, which according to the literature would indicate the presence of strep mutans. The other test, the pH test, there was a trend here, but it didn't really have good diagnostic performance as far as the sensitivity and the specificity. Okay, so we figure though, we would rather, okay, once again, so now thinking about if we're wrong, what kind of wrong is good for the patient or bad for the patient? Okay, so for cancer diagnosis, we don't want to miss cancer. For caries diagnosis, we do not, it is wrong, it is bad to have false positives. It's bad to drill and fill a tooth that doesn't need to be drilled and filled. For risk assessment and for giving patients advice, we do want the sensitivity. If basically a person doesn't have risk and we tell them, to basically correct their oral hygiene or watch their diet, we're not really doing that much of a disservice. Okay, so how does this work in the big picture here? So this is a recent publication, and you can see this is Rutgers Dental School, the best and the brightest here, right? Okay, that essentially basic research translates into clinical research, and then clinical practice basically generates questions that are then funneled back into the research system. So it's sort of a never-ending cycle of innovation and testing, okay? All right, so I thank you, and I think we have a few minutes for any questions.